Welcome to episode 239, The Overlooked Connection, Dyslexia, Dysgraphia, and Dyscalculia, and the Mental Health Impact, featuring Dr. Robin Raniero Norris, licensed marriage and family therapist. Make sure to subscribe to be alerted about future episodes. By Clearly Clinical. Learn, grow, shine. Hello to our listeners. My name is Beth Irias, and I am looking forward to and excited for the conversation that I'm going to have today with Dr. Robin Raniero Norris. She's a licensed marriage and family therapist, and one of her specializations over the years has become a focus on specific learning disorders and how they show up in therapy, how we recognize them, how they affect our mental health. I'm so excited for this conversation today because this is really one of those topics that we don't talk about enough. Thank you so much for joining us today, Robin.
Thank you for having me, Beth. I really appreciate it.
So before we dive into a very big topic, why don't you tell our listeners a bit more about yourself and about kind of your work in this specific space relating to specific learning disorders like dyslexia?
Sure. So I'm a licensed marriage and family therapist and a professor at the College of William and Mary, who actually focuses mostly on financial therapy. However, in working with my own family and friends, I've discovered that literacy and learning disabilities and disorders are an important part of everything we do.
Indeed, they are. I shared with Robin before recording this topic is very close to my heart. I have a number of people in my life that have specific learning disorders. And in my experience loving them and understanding how it's affected them, I really appreciate the focus that Robin has in bringing our attention as mental health professionals to them, because I know even now we really think of these as like educational issues. And I know in my bachelor's and master's education, there was very little discussion about this, but now we know much more about the consequences of undiagnosed or underdiagnosed or unmanaged learning disorders. So kind of as the background, Robin, will you please dive in and define, when we say specific learning disorders, when we say learning disabilities, what are we talking about?
Sure. So when we think about it in terms of the DSM-5, we're thinking about it in terms of a disorder. When we're thinking about it from an educational space, like in elementary school, middle school, or high school, we're talking about a disability. The three main types of specific learning disorders are involving reading, mathematics, or written expression. So they're known as dyslexia, dysgraphia, and dyscalculia. Dyscalculia is the math one. The written expression is the dysgraphia, and dyslexia is the reading one. The biggest misperception about reading is that it's actually not always about your eyes and how you look at things, but it's actually a language-based disorder. So it's a neurological disorder in which different parts of the brain aren't necessarily talking to each other in the way that we would normally think that they would, so that we could absorb words through our eyes.
In our culture, being able to read and write is foundational to moving comfortably and safely through the environment. Can you break down these three a little bit more and describe how those manifest and how they affect somebody in the real world from a practical standpoint?
Sure. So when we think first about dyslexia and we think about what are reading components, because there's a lot of words involved in these three topics that we as mental health clinicians don't always get. They kind of stay encapsulated in the educational space. But when we think about reading, we want to talk about how we decode words and what language comprehension then looks like. So am I looking at a sentence and am I reading it quickly? Do I have an accurate interpretation of the words? Am I reading them fluently? And then after I've read them, do I actually comprehend what I've read? So if I look at a sign on the street and it says, "Don't park here," did I read it quickly enough so that I knew that I shouldn't pull in here? Did I read it accurately? Did it say "don't park here"? Or did it say "do park here"? Did I read it fluently? Was that word "park" or part? And am I even understanding what I just read? What does this sign mean? And so when we talk about the world around us, it doesn't stay encapsulated in school. It doesn't stay stuck in a book. It's all over the place. Every single package we pick up has words on it. It has numbers on it. We cook, it has measurements on it. We have emergency signage in all sorts of buildings, right? Go here, go there, meet here. How do you find the location? And so we want to be able to talk about processing speed. Are we comprehending? Are we able to what we call decode? Are we able to take these words and actually make some meaning of them? Or are we taking best guesses?
From a practical standpoint, best guesses work to a degree. And I think for people that don't have a specific learning disorder, where I've experienced this phenomenon most obviously was being in another country, where you may have a certain number of, amount of knowledge or none at all. And then you're trying to navigate the world being like, what does that sign say? And you're talking to someone and you ask a question and then you're trying to figure out what in the world they just said to you to decode it. For the person who has dyslexia, when does this start emerging in their lives? Well, not when does it start, but when does it become most impactful in their lives and we start to see that this is really creating functional difficulties in the world around them?
That's a great question. So I would say actually pretty much as soon as they're able to consider language a thing, a written thing, which can be as early as 1 or 2. Dr. Shaywitz at Yale University had discovered that dyslexia can happen in up to 20% of the population. So we talk about 1 in 5. And when we think about that, that to me is a very genetically packed scenario. So when you say, when does it affect? Well, is it affecting a parent having a child in the hospital who doesn't always know how to read the paperwork they're about to consent for the baby they may have? Or does it start that next generation possibly for that child when they go to preschool? Or when they're interacting with board books. Where it really becomes impactful is when they start to realize that their peers may be learning differently than them in kindergarten and first grade, and then so on and so forth.
From an emotional perspective, and we'll dive into this more as we're talking, can you elaborate on what this looks like in the day-to-day for a child, an adolescent, a young adult, an adult who's in an environment where there's just this blanket expectation of being able to proceed with a certain skill and then not?
I think that's the most important part, is that they can't, but they keep trying. And sometimes I think as educators and as providers, we see the attempts and their successful attempts, which then confuses us. One of the best analogies was one of my friends had talked about a flickering light bulb. So sometimes a light bulb is lit solidly, but other times it might have a little bit of a flicker. And within that flicker, it hasn't completely dulled out, but it's not completely solid either. And so it becomes like these little hiccups, right? And as we're hiccuping, we're missing content. So if I'm a student and I'm in class and the teacher's in front of the class talking about something and my brain kind of goes to left field for a second and then comes back, I've missed the content that's been presented. So now I'm kind of looking around at the other kids to try to mimic what they're doing, or I'm trying to catch up, or I'm looking down at my paper. And so when we talk about dyslexia and dysgraphia and dyscalculia, we've got to remember there's a processing part where there's always a catch-up. There's always a catch-up. And when we feel behind, that can be quite stressful. One of the areas that I've worked with most in my career in the last 20 or so years has been trauma. And we think about stress and we think about trauma, we think about what does that do to the body, right? We can have headaches, sleeplessness, we can have weight gain, we can have bowel issues, muscle fatigue, teeth grinding, ancillary effects can be anxiety and depression, heart rhythms. So if we think about, this is traumatic every single minute of every single day when a child is in school and they feel like they're learning in a foreign language always, and they're now being asked to write and interpret in a foreign language always, it's very stressful. Vander Kolk had done a great job years ago of talking about what stress does to the body and discussing fight or flight. And I think we need to expand our definition of what the fight or flight responses are, because we have essentially 3 or 4, but I've also noticed a 5th one within the community of individuals with learning differences. We fight, we flee, we freeze, we fawn, but we can also fix. And I can break those down for your listeners if you'd like.
Please do. And I would also, I really look forward to hearing you elaborating on fix.
Sure. So when I think about the concept of fight, if I'm sitting in a classroom and I can't read, I'm going to either argue or pick a fight or maybe disrespect the property. I'm going to maybe throw my book to the ground. I'm going to act out, right? That's my way of, I don't get this, but I don't want to say I don't get this because I don't know if I'm getting this or not getting this. So that's our flight version. When we have the flight version, we want to run away. Get me out of this classroom. I don't want to go to school. I want to go to the nurse. I want to go to the bathroom. Can I go see the counselor? Right? That's how we're going to fly away out of the classroom. Well, we can freeze, right? We know in traumatic events, we go inward. We stay silent. We look like the child that's zoning out, quiet, compassionate, not doing anything, not disrupting anything. And in a classroom of 30, the non-disruptor is a good kid, but they're freezing. They're going inward. We can have fun, where it's all good. We're going to fake it till we make it. Right? We're going to be that best guesser. We're going to say, oh, that's exactly what that was. Oh, haha, I was just testing you. I mispronounced that word, but I knew it. Right? We're going to fawn. Well, in the world with folks with specific learning disorders, I've realized there's fix. Sometimes these are the students and the individuals that say, let's try to do something. They're the helper. They're the rescuer. Oh, I'll go bring that down to the office for you. Oh, do you need somebody to walk that person to the nurse? I'll do that. And what it can look like in an adult space is if you have, let's say, a warehouse and the lights go out, you can have somebody that's, oh, I knew this was going to happen. That's your fighter. I can't believe they didn't pay the bill. Or the fleer. Oh my gosh, how do we get out of here? Quick. Where's the wall? Where's the wall? Where's the elevator? Where's the everything? Freeze. Somebody's going to go under their desk, start saying a few things to themselves, just to calm down, and go inward. And then you've got fawn. Don't worry about it. Lights will come on eventually. Just chill out. But the fixer is the person that will look around and say, okay, hey, how about you try the phones over there. Here's a phone. Try calling somebody. Hey, here's where I think the elevator is. Why don't you walk that way and see if the stairwell is next to it? You have this point person that may not ever have been a firefighter, may not have been a paramedic, but they go into this fixing mode. And I've seen that with the kids with dyslexia. They can be the ones that can point out somebody getting bullied. They can be the ones that have this moral, ethical justice space. And that is their escape hatch for reading, writing, and math.
That all of that and the way that you just presented it is so interesting to me. These are all strategies, whether conscious or not, for surviving in the world, for navigating and for getting by.
Some of these strategies get positive accolades, right? You're such a great person. You did such a nice job helping that student. You did such a nice job walking your friend to the nurse. But then other ones, if I'm the kid that throws the book to the floor, I was a disruption. I was a behavior management issue. So this is why I wanted to bring this topic of learning disorders and learning disabilities into the field of mental health, because we have a lot of discussion to have that didn't look at it in this frame of reference.
I absolutely want to talk more about this. And I'm also realizing, okay, we have these other two terms that we haven't defined yet. Before we go deeper down rabbit holes about kind of the manifestations, will you talk more about dysgraphia right now and kind of the implications for someone navigating the world? And then we'll move on to dyscalculia.
Absolutely. So dysgraphia involves handwriting. It can have poor spatial planning on paper. You can have challenges organizing thoughts coherently. You can have difficulty with writing speed or grammar and syntax. So dysgraphia can also come up when typing. I think the misnomer is that dysgraphia is only with handwriting, but it can actually involve the motor parts that involve the production of language through our fingers.
So in terms of how this appears in the classroom, in therapy, tell me, how does a clinician notice that something's going on here?
They might not. And so this is the tricky part. If you have somebody filling out their intake form, is it left blank? Does it look legible? If you have a child with a homework assignment or you want them to do an art project, do they reject the assignment? Do they gracefully find a reason not to do it? So it's tricky because we don't ask people in our intake process, how do you feel about reading, writing, and math? We don't invite the conversation. I think by accident, we as clinicians have taken literacy for granted, and it's a privilege that somehow or another we have managed to master to get to where we are. But it's one that I think we forgot that we might need to start at the very, very beginning and ask, how do you feel about the form?
I have so many more questions I want to ask, but I want to get to dyscalculia before I start asking those. So please elaborate more on dyscalculia and then how that may...
Sure. So dyscalculia can be difficulty with number concepts. You can have challenges with basic arithmetic. You may rely on your finger counting or markers for calculation. You can have difficulty with spatial orientation. So that's left, right, back, forward. You can have struggles with money management, avoidance of transactions that might involve cash, because there's really no understanding of whether I gave you a $5 bill or a $50 bill and whether you gave me the proper change back. There can be challenges with working memory and sequential memory. And then the last one I think that can also come into this is difficulty understanding and managing time, both with dyslexia and with dyscalculia. Some individuals do not have an internal time rhythm to themselves, and so they may be late for things, they may be very early for things, they may put it on their calendar incorrectly. There's actually research at Georgetown that will show that you cannot necessarily always read a clock. The numbers may kind of fall off the edges like a Salvador Dali painting, and so we have to be conscious as clinicians that they may not have time management in addition to money and number management.
Thank you. And thank you for that example. For our listeners, if you haven't heard it, I really recommend the episode that we have with occupational therapist Robin Abbott, where she talks more kind of about time awareness and time blindness and these concepts. So I just want to piggyback. Coming back to these three specific learning disorders, one of the things that I did not learn as a mental health professional and that I learned through life was the comorbidity, co-occurrence between specific learning disorders and some medical conditions. There's no way, number one, that we could name all of them. And number two, that we could speak to them appropriately, because you're not a medical professional and I'm not. But I would love for you to kind of talk about that, because I have seen it real time in my old life, how medical conditions can contribute to the development of one or all of these three, and how easy it would be to mislabel or misinterpret them.
Mm-hmm. So we do have to remember that it is a neurological, genetically based space. So while a medical condition could induce one of these three items, onto themselves they can happen. What happens with the comorbidities gets fascinating because quite a few folks that have dyslexia may also have ADHD. A person with ADHD could have autism. So it becomes this space of how do we rule out and how do we rule in? I saw a psychological report recently that used the Connors test. It was a educational psychologist had done this for a 7-year-old female at a school system. And when I saw the reports for the teacher and the parent, the Connors looks and tries to match up different DSM-5 disorders that the child could be having. This particular child's list included ADHD, conduct disorder, oppositional defiant disorder, major depressive disorder, manic episodes, generalized anxiety disorder, separation anxiety disorder, social anxiety disorder, obsessive compulsive disorder, and autistic spectrum disorder. And she scored high on all of them. I sat back with that for a minute and said, does she have all these disorders? Now, I'm not her clinician. This was just a report that was shared with me. And I went and I looked more at the report. And there's another test there's a bunch of other tests that psychologists can do that can look at reading and writing. One is called the CTOP2. And when I looked at the CTOP2 scores, I saw, oh, we're in the 9 percentile for reading, 9th. Then I kind of went back and looked at all of the rest of the report and discovered that they chose not to write about specific learning disorders. There was no word dyslexia. But the treatment plan, from the school's perspective, was pretty spot on. It was actually quite accurate in terms of how they were going to manage the disability, because I think that at some point they acknowledged that it was a reading issue. However, if you don't know all these nuances and you haven't met with this child, you're looking going, how does this child have 11 things potentially? Now, could she have 1 or 2? Yeah, absolutely. But if you can't read, you might feel anxious. If you can't read, you might feel sad. If you can't read, you might throw your book down. You might not want to listen to the teacher. I'm trying to get in the head of the 7-year-old little girl. And when I asked the clinician, I said, do you see any signs of these types of things? How was her eye contact? Was she clinging to her mom? Was she willing to, come to you and talk with you? And this clinician said the child looked like a normative child with no issues at all about speaking to her, looking at her, no opposition, wasn't running around the office wanting to go home or crying. And so they had a discussion about reading, and sure enough, the child has a reading disability.
In that case example, if you'd like to share, either in reality, obviously protecting the person's privacy, or kind of to imagine, let's say it gets acknowledged, it gets diagnosed, how does that change the life of that child? The example that you just gave, and I've seen it. I think many of us have seen it, whether we've seen it clinically or outside the therapy room, where you have a kiddo or an adult that just has this laundry list of diagnoses. And I've had the same experience where it's kind of like, what's at the root of all of this? And is there actually something that we're missing that makes all of this make sense in context? And like the example that I'm thinking about, and I, certainly recommend to our listeners to listen to the episode with Dr. Roseanne Capana-Hodge, but talking about PANS pandas, which one of the symptoms of that is dysgraphia that can be exacerbated by an autoimmune flare. But so you have a child who's going to be diagnosed with a specific learning disorder, with ADHD, with oppositional defiance disorder, with anorexia, with this laundry list of things, and it's actually due to a medical condition, or it's comorbid alongside a medical condition. And I'd love to hear more on your perspective, because like we started at the beginning, so often we think of these things as being like, oh, well, that's medical or that's educational, and not appreciating how it all fits together and also plays out for someone's mental health.
Absolutely. We need to not be siloed, and we need to look at this as a team effect. What I mean by that is, as a private practice mental health person, we wait for the school to give us information. And sometimes we get it and sometimes we don't. And the school kind of sometimes waits for us to give them information. And what a lot of these children can do is that they can mask some of their struggles for a pretty long time, couple years worth, and then all of a sudden it hits this 4th and 5th grade, and then it becomes this real question of, well, is it hormones? Is it the middle school blues? Is it, right? We start to talk about all these other possible things, not thinking, oh, wait a second, they've been struggling to read and write since kindergarten. And so that's when you start to tease out the different parts. I think as mental health clinicians, we're very good at determining the difference between autism and ADHD, or ADHD and oppositional defiant disorder, right? We've got our really good checklists, but I don't know very many practitioners who have a checklist for dyslexia, dysgraphia, and dyscalculia to say, I'm not here to diagnose this, but I could be here to assess. So I'm figuring out, am I sending you to a psychiatrist, or am I sending you to an educational psychologist for additional testing? Because that's a totally different route. So when you talk about how does this affect a child to know that they have this or find out as a family member, it's life-changing, it's life-altering, because the path that you determine as a referral is completely different. Now, that doesn't mean they might not have ADHD and might need medication for ADHD, but if they have a reading piece to it as well, then all the medication in the world isn't going to help the person become a reader.
The process for an accurate diagnosis for the 3 of these in our current system can be lengthy, expensive, complicated. If you are a clinician who is either working alongside an educational or psychological team that knows this and is investigating it, or you're the one saying, I think we should probably look into this more, here's a referral. How do you work with clients and families to kind of understand? Because as a culture, we have so many norms that we just expect, and there's a lot of shame associated with any diagnosis. Can you expand on all of that? Like in the early stages, how do you talk to clients and families about this?
Right. You remind them that they're not alone, that they can feel very lonely and scared, right? You meet them where they're at, because this can be very terrifying. This could actually be uncovering things for the parent or the parents' parents that was never discussed. So you help them to find what I would call local free resources first, in addition to the referral that might take 3 months to 6 months, that may or may not be reimbursed by insurance, that may take a lot of time for testing. You also refer them back to their schools. You help to educate the individual, and through the education, it becomes less scary. You start to understand the potential for success and the potential of the learning difference. And there's a lot of things that parents can do at home with their children if they just know. When I started this journey, it was about 2 years ago, and I worked in collaboration with I'm still currently working in collaboration with the public schools, the Chamber of Commerce, and the public libraries, because I felt like there was this important triangle of individuals that the clinicians, the parents, and the kids were in the middle of the triangle. But if I didn't know where to send people to in terms of free resources, that was going to be a problem. So more and more public libraries are now starting to have different resources for the community, that are audio resources, that are visual resources, that are also written resources. And so it's about not being alone. That's where you start with when you think something's not looking right.
I was reading an article recently that there was a study that found that people who had a diagnosis of ADHD, they found had a shorter life expectancy. One of those reminders of the dangers of these silos. What are the risks to people that have underdiagnosed or undiagnosed specific learning disorders in terms of mental health conditions, in terms of their safety navigating in the world? Can you expand on that a little bit?
Sure. It starts off with self-esteem and how do you feel about going out into the world where there's writing everywhere. One of the biggest risks for the teens is, are you going to complete a high school education? And what does that mean if you don't? Right? We can recognize trade schools and colleges and all sorts of different things in our U.S. society that are important post high school diploma. But I think we all kind of had agreed that a high school diploma should be our bare minimum standard, right? And that it's good for adolescents to have these experiences, to keep growing and keep learning as their brain is developing. So they're more at risk for school refusal. They're more at risk for not completing a degree. They're more at risk for anxiety and depression. And the concept of, if you're not feeling great, what do? You sometimes try to self-medicate. So there's a higher incidence of the possibility of choosing drugs and alcohol to self-soothe. When we look at the possibility of not being able to be employed or being less employed or differently employed, sometimes that comes with financial stressors. Some people may end up in the criminal system. There was a study in Texas that looked at literacy, and it's very, very difficult to have studies run fully with inmate populations, but it came up with that 48% of its population had some sort of learning disability. And sometimes the literacy issues don't get caught until the individual is in prison. If they're not in prison, then the rates of suicide can be higher.
Thank you. Thank you for kind of speaking to that reality. When it is caught, what does management look like for one or all of these conditions? And how, understanding that every body is unique, but kind of looking at a management course, what does that typically look like? And how reasonable is it to expect acquisition of skills, and to what degree?
Right. No, that is a question that I'm still continuing to learn myself, because it's a spectrum. It's a rainbow. Some folks are very low in terms of processing and abilities to decode. Some people are much more efficient and effective at decoding. Some people can be remediated a bit with handwriting. So it takes a team, though, because some children or adults may need to go to occupational therapy. Some folks might need a speech and language pathologist. Others can learn from an educational psychologist. They may need to see us as clinicians to learn about different coping strategies and different skills management strategies. Different types of teachers know different things. And even in the best of educators, sometimes we don't know how to see the world through another person's eyes. And so, a lot of times we end up helping the client to become their own advocate, to say, this is my hidden disability. This is my hidden superpower, because it can be both. And so it can look varied. My hope for all folks with dyslexia is that they can get to what I would consider a literate societal reading space, so that the danger signs, literally, the danger signs we put out there are ones that they can understand and comprehend.
When thinking about working with people who have SDLs in therapy, children or adults, what are some of the considerations that we need to keep in mind? Like you had mentioned about intake paperwork. Again, these things that we're so used to doing. And it's been my experience talking with specialists in various things over the years. It's like you talk to somebody who has a specialization in traumatic brain injury, and they're like, have you asked your client on intake if they have ever been hit in the head really hard? Like that we might not be asking. And they're like, oh, no, I haven't been asking that. Can you expand on some of those considerations so that we as clinicians can make practices and policies and procedures that are more inclusive and supportive for people with SDLs?
Sure. Yeah. So it really does begin at the intake and the conversation. And it's okay if the first 3 questions are about reading, writing, and math. And it, to me, should be right after their name. How do you feel about reading, writing, and math? And in some instances, it might be at their name. Because if you happen to have a name that has a letter that might jump around, like a B might want to go to a D, then you might even say, tell me more about your comfort level of filling this form out. We, again, as clinicians, have these standardized things. We're very book-read people. We love to give resources. Oh, did you see this? Here's this book. Why don't, couples counselors, we give them books all the time, right? And it's a matter of, well, do we need to have this as an audiobook? Do we need to have this as a printed book? Just making it available in our waiting room that we can talk about these things from that point of view, having things on our website. When we talk about things we can do as clinicians too, we can be font friendly on our intakes. There's definitely a bunch of different types of fonts that we all have access to on our computers that could make it a little bit more spaced out, a little bit bigger. So it's just that understanding that we're not all coming at the world in the same way. And being a literacy advocate is really where it begins. So because that encompasses TBIs, it encompasses LSDs.
Yeah. Another one that I was thinking of that I've learned over the years is contrast, the importance of contrast. And I can also see the role for clinicians as advocate for things like IEPs and trying to help support particularly academic environments, but even potentially later occupational environments to wrap around and have an environment that is just more aware and more supportive so that a person has a better chance of succeeding in that environment. Can you talk about what some of those might look like? Like you just gave some about like audiobooks, but thinking of the IEP meeting, if a therapist is in that meeting and they're considering, does this child actually need an individualized education plan? I can almost hear the echoes of a clinician sitting in that room saying, well, let's talk about this if we don't.
So I think even for clinicians, knowing what the difference is between an IEP and a 504, because some clinicians don't even know this language. So a 504 can cover things like other health impaired, but an IEP is actually going to have it's an individual education plan, but it's actually going to have a specific set of goals. So a 504 may allow for a child to have extra time to complete an assignment, but an IEP may actually pair a reading specialist up with a child or a speech and language pathologist up with a child so that they can get the specific interventions they may need. And I do think that the advocacy space is there because I found it in my own community when I went to the public library and didn't find any decodable books and didn't see any presentations about dyslexia and didn't know that individuals such as Agatha Christie, right? I didn't know Agatha Christie was not actually typing her things in. She was using a dictaphone and her nephew was typing on behalf of her. And so knowing that a person with a reading and writing disability can still become an author was so empowering, both as a parent and as a clinician, that there are so many different places we can be advocating and teaching, because that's what we are. We're the heart of teachers. And that's what advocacy is. It's explaining things to the public or our clients or our family in ways that they might not have heard it explained. And then being able to provide resources that are useful intangible.
Thank you. I love that example. And I also appreciate you talking about some of the differences and similarities between individualized education plans and a 504, which is a medical plan, and that sometimes there's overlap between those two. For those of us who do not have as refined a skill as you do in recognition and kind of seeing the ripple effect of SDLs, can you share some case examples of things you've read, things you've seen, people you've worked with to kind of illuminate this for clinicians that are like, yeah, but what does that actually look like?
So it can look like a person who comes in and is, for my examples, for financial therapy. It can look like a couple that comes in and is stressed out and fighting about their budget. And then you keep digging and you keep digging. And then you say, do you like numbers? And the person goes, oh, I always hated math. And then you say, tell me more about what it was that you hated about math. And then they start to say, this would be session 4. They'll start to say something like, oh, those numbers, they just don't make sense to me. And no matter how many times I calculate them, they don't stick. But all he or she wants to do is talk about numbers and math and budgets and tell me I can't manage my money. And then you start to just ask more questions about their prior education. And they can be in their 30s, 40s, 50s, and 60s. And you say, well, what was it? Is there something beyond just being good or bad at math? And based on that, you can actually end up finding individuals that you need to refer for testing as adults who may not have realized they had possibly ADHD or possibly dyscalculia. And so you just kind of meet them where they're at and determine where they're stuck. And then when you're stuck there, you ask one more question a little lower. What is the stressor? The stressor for this couple is they can't talk about their budget. So then it becomes, tell me more about what it's like to talk about numbers. And then that's when all of a sudden you start to hear about the shame and the guilt and the secrecy and the hiding and the, oh, I faked it in math class, and oh, I stole from the till when I was, 20 because I couldn't figure out how to manage the budget and rent. And lo and behold, you have these two individuals who can be quite successful, but have never actually had that discussion with each other.
Thank you. I think that was a great example. What does testing look like? And, in our current reality, often when we refer to a psychologist for testing, I've encountered wait lists anywhere from 3 months to 18 months. So there's a long wait, and you talked about kind of the payment piece. Can you talk about some of those realities who, for the clinicians who are like, oh my God, that one client, and like kind of what they might need to know as they think about a potential referral and all of that?
Right. There can be an absolute cost that goes along with all of this. And that too is something that as clinicians, we need to recognize, what does this look like for the finances? The testing can cost, depending on where you are in America, can be anywhere from $2,800 onward. I've seen it as high as $4,200. It can look like a 3 to 6 month wait for a educational psychologist. And then it can be a 1 day where you're sitting with this individual and going through different types of cognitive tests and reading tests. One of the things full testing can, like I said, cost the thousands. One of the other things, though, that I think can be used as a stopgap in the meantime is to look online and find some assessments that aren't necessarily clinical tests. There are a lot of different places you can go, like the International Dyslexia Association. They have assessments that are quick and easy. Your spouse can ask you, a parent can ask a child, your neighbor can ask the child if the parent can't read. And it at least gives you a starting spot to say, do I think I have this or do I not? Which is not a great feeling to say this as a clinician, truthfully, right? Because I think I love normed things. But in this instance, it really feels like we have to plug up the dam with sandbags for right now until we can build the structure, right? We don't diagnose on the master's level as LPCs, LPCCs, LMFTs, social workers, but that doesn't mean we can't help with the assessing part. What do? We ask questions. If we ask enough questions and it looks like, wow, 8 out of 10 of these things that you've answered, or 18 out of 20 of these things that you've answered, seem like you might have some struggles in this area. Let's talk about this some more. So that for me is this stopgap between I've got the perfect diagnosis from the educational psychologist or the psychiatrist and this lingering I won't know for 6 to 8 months, because that's an awful long life to live without that. There's other individuals in the meantime we can be referring to. We can be referring to reading therapists who can also have a lot more background in this than us, to be able to say in 1 or 2 weeks of meeting with a person, oh my goodness, yes, or no, I'm not seeing that, So that's where I do think that, a reading therapist can be $75 to $150, which is a big difference between getting the full amount of testing. And I don't see any harm, because one of my goals for being a clinician and a professor is do no harm. I don't see any harm in somebody sitting with a reading therapist who has this knowledge to be able to kind of look at it a little deeper.
We've talked about kind of the normalization, for somebody that it's finally recognized, they can finally receive some education. I've been in the circumstance as a clinician where I may suspect that, but it's out of my scope. And the person or family is not able, for whatever reason, to access the testing that could make this concrete. Through your eyes, what are the biggest incentives for a concrete psychological assessment-driven diagnosis? And how does that facilitate more self-esteem, more resilience, less shame, more functional ability for somebody, both in childhood and in adulthood? Like, should a 34-year-old go and spend that money and that time to get a diagnosis? And what does it mean for them after the fact? What interventions might they receive that could be helpful?
Right. So with the children, it can go back to the schools. The schools do have the capacity to assess for the learning disabilities. They don't diagnose, and that's the biggest difference. They don't diagnose, but they have the capacity to assess. There was a Department of Education document back in 2015. It was a guidance document that actually says schools are allowed to use the term dyslexia to ensure accurate support for the student. A lot of school systems don't use the word dyslexia because they say it's best left for the neurocognition or the educational psychologist in private practice. But I promise you, there's a DOE piece of paper and actually a video on YouTube that goes with the originator of the piece of paper that says schools are allowed to assess and use the word dyslexia. They can also use the words dyscalculia and dysgraphia. So if you have a school child, I absolutely would go back to the school team, which could be the special ed director, it can be the assistant principal, it can be the social worker, it could be your child's teacher, to say, I think I need more something, right? And you can ask for testing. You write it up, you ask for testing. And even that process of writing it up, right? You have to have a written request for testing. Now, if you're a parent with dysgraphia or dyscalculia or dyslexia, writing and emails and may not be your thing. So that's where you now have to admit to others, I need even the next step for assistance. Through that, you can have that discussion with the schools. Now, again, it can take a long while before a child is matched up with interventions because they're going to try to keep helping the child as best as they can without the IEP simply because there's not enough resources. There really, really isn't. And this is where I do not fault schools or teachers or assistant principals, or they are trying. If this is truly 1 in 5, there is more of these individuals that need specific help than there are space, finances, and people.
I'm glad you bring up that point. It's a tough reality, and I think it's an important one for us to keep in mind, that there simply are not enough resources. And depending on the school district, it's been my experience of like sometimes there may be enough. And so it's like, okay, I requested it. And within weeks, we got this, brief assessment set up, and then we got it in place, and that was easy peasy. And then I've also worked in other situations where it took months, if not a year or more, and it involved attorneys, and it was very stressful and not an easy process. But so I'm glad you brought up that point, because I think it is one of the access issues. What can be done non-therapeutically? What is done for people that, let's just say, have dyslexia? Are there workarounds that can realistically help them navigate? And is that through primarily occupational therapy? Like, what are the referrals we need to be making, and what are some of the interventions that might be done?
Sure. So OT, so occupational therapy, can be one referral. A speech and language pathologist can be another referral. Now, interestingly enough, a developmental vision person may also be another referral, but this goes with the comorbidity. These items are not visual issues. However, they can have sometimes visual issues that go along with this. So some kids may need reading glasses. Some kids may need specific types of reading glasses. And so it's not common that a counselor think, oh, I should send somebody to a vision specialist, but they actually might need to have a developmental vision specialist in their cachet of individuals to refer to. Definitely the educational psychologist, working with a psychiatrist or a pediatrician who understands this, because that too is important. The pediatricians are absolutely allowed to assess for these things. It does not have to be the specialty neurologist in town, because it needs to be this conversation. Because if we're seeing people that have 8 out of 10 or 18 out of 20 or just aren't feeling good about these 3 things, then it tells us something more. It's that lived experience part. It's that qualitative space that we may not have reached just yet with the quantitative measuring tools we had. And you'd ask that question about, what do you do with the 35-year-old or 45-year-old? Should they go do all this extensive testing? The question would be, for me with them, is what will you gain by knowing this? Because it may be that they want to have this diagnosis so that they have a better handle on describing it to people if they're in a college. They may want to be able to explain this differently to their employer. Or they may want to say, oh my gosh, that is me. Now I get it. Where's my tribe? Because that's the other part, is there is more and more and more amazing people that have so much creativity. So we're talking about so much of the clinical side, but there can be the strength side of this learning difference. And so if that person needs to have this solidified so they feel like they know, and let's say they want to know because this can be genetic, right? I want to know because I'm going to have children, or maybe this is something I need to watch out for my kids by the time they're in kindergarten. I might need to have some more conversations than I thought I would. But if they're doing it and they feel like they have to be whole, and they don't have the financial resources, then yeah, it's our responsibility to help them dig further about, is this a necessary choice to get tested?
Thank you. I really appreciate you bringing up that point. And I know I've been in that situation as a clinician in various ways, working with adults, where it's like, hey, I think this might be going on, and having that exact conversation of like, what would it mean to you if you were diagnosed with autism? If, whatever it is, because we don't operate in an environment where these are easier, inexpensive things to get. And so that can have a major consequence for someone to spend all this time, take the time off work, spend thousands of dollars and go, okay, I have this piece of paper and I did all of that just so I could have a diagnosis code that, yes, validates my lived experience, but from a practical standpoint may not actually benefit them. So thank you for bringing up that point, because I think it's one that it's kind of where fantasy meets reality. like what's actually possible in the system as it exists, and how is it going to change your life, with work in particular. So thank you. I appreciate you bringing up that point. During our conversation today, you've mentioned a number of different resources for clinicians who are listening. What do you think are the best places, podcasts, resources, websites, books, whatever it is, for them to learn more about this, not only just about these 3 SDLs, but also kind of the mental health impact and how it shows up in therapy?
Some of them are children's books and some of them are more academic, but my first and favorite book on dyslexia is called Brilliant Bia, and it's written by Shana Rudolph and Mary Vukadinovich. It's actually got an amazing set of information spaces in the back from the American Psychological Association. It was an APA publication. And so even if you're not sure what this is, I think this is a really, really good primary book to start with. Quite a few of the public libraries now have it, and if they don't, that's another space for advocacy. Our public library didn't have it, so I had to learn how to navigate requesting a book. I didn't know that was a thing. But, and I do believe that they do listen to clinicians. They want to hear mental health voices. They want to understand why we think this is important for the public to have. So Dr. Ellen Brayton wrote the reader's notes and goes into extensive information about what is dyslexia and things like accommodations. Another book I found actually is not a APA type book, but it was written by an adolescent on dysgraphia because she was doing a Girl Scout project about the topic. One of her neighbors had dysgraphia, and she did a really good job in the back of the book with, again, different resources. It's got how does it affect the child or the person? What do you do for professional help? It's got tips and exercises. And this book is called Writing Right by Cassandra Baker. These two are fantastic beginnings. When you want to actually do a deeper dive into the mental health space and have it be a bit more academic, there is a book called Dyslexia and Mental Health: Investigations from Differing Perspectives, and it was written and edited by Neil Alexander Passay. He happens to be a professor in the UK. And that has different chapters on all of the different types of comorbidities and effects this has for individuals' lives. And then the last book, because again, here we are, book heavy people. The last book that I've absolutely really adored and am looking forward to meeting the author of is called Undiagnosed: The Ugly Side of Dyslexia. And that is by Amir Baraka. He shares his story in this biography of how his dyslexia was not discovered until he was already in prison. He has since been happily released from prison and is an advocate for children in Louisiana and is a Hollywood actor. And so when I look to somebody who has lived the experience as a young Black boy who became a young Black man who realized, oh my goodness, wow, I made a wrong turn in high school when I dropped out and had issues, and this cannot be left behind anymore. His experience, I think, is a good one for clinicians. There was also actually a video that I discovered on my journey of finding things that was composed by a clinician herself when she discovered she had dyslexia. The video is called Read Me Differently, and she actually interviews her own family members about her dyslexia and their reading struggles. So that can be another resource. The other two resources that I love is The Right to Read. That involves a person named Kareem Weaver. And it was funded and supported by LeVar Burton, who used to do Reading Rainbow. And he actually goes into different classrooms in America, and he talks about the struggles some families are having and the conversions that some teachers are making about children's literacy. And the last one that I've loved is called The Truth About Reading. That too is a video. And I'm not usually partial to topics like the truth about anything, because to me that just always feels a little not true or really kind of questionable. But The Truth About Reading has been fascinating because it looks at adults' journeys. And you will see very successful individuals talk about their workarounds, their moments where they had to fake it until they made it, until they became old enough where they said, I can't live like this anymore, and I really want to learn how to read. I really want to understand what is not working well for me. So I honestly think if you're a clinician and you get those resources, you'll be leap years ahead of where you ever were with this topic, with just those few movies and those few books.
Thank you. I think these are incredibly helpful resources. And I'm sure for you, the reason you know them and recommend them is because they were really helpful to you as a fellow clinician. Again, for our listeners, we've had the pleasure of listening today from Dr. Robin Raniero Norris. And Robin, what's the best way to learn more about your work and how to get in touch with you?
Sure. You can go out to my website, which is Windward Optimal Health. The website is www.wind-opt.com. Or you're more than welcome to find me on LinkedIn, or most recently through Decoding Dyslexia, Prince William County, Virginia.
Thank you. You've come on and shared so much helpful information. I sincerely appreciate not just coming and talking to us, but also the work that you're doing to try to bridge this gap. I think it's really significant. So thank you for coming here today.
Sure. Thank you for having me.
You've just finished listening to another exclusive Continuing Ed podcast by Clearly Clinical. If you like what you just heard and you need Continuing Ed credits, please visit us at clearlyclinical.com to check out our one-year membership, where you'll have access to our growing library of Continuing Ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.